On behalf of the Agency for Care Effectiveness, or ACE in short, I would like to extend a warm welcome to all of you for joining us today. I am Jeremy, your MC for this seminar. The seminar, Approach to Assessing and Managing Headaches as the Presenting Symptom, is organized by ACE. ACE was established by the Ministry of Health in August 2015 as the National Health Technology Assessment Agency to drive appropriate care and manage healthcare costs in Singapore. Ladies and gentlemen, without further ado, please join me in welcoming Dr. Daphne Khoo, Executive Director of ACE, to give her opening remarks. Dr. Khoo, please.
Thank you very much for joining us today. This is actually the first event that the ACE is holding in person ever since COVID broke out. I wanted to tell you a bit about the ACGs that ACE produces. As you know, MOH has been producing clinical practice guidelines for many years, and around 2015, 2016, we started switching to appropriate care guides. So why did we do this? First of all, most countries actually produce clinical practice guidelines, and clinical practice guidelines are applicable both to specialists as well as GPs. However, in MOH, in the years preceding the formation of ACE, you would have noticed that a lot of the CPGs actually focused on CDMP conditions for GPs. And so over time, the ACG, CPG space has actually evolved to be primarily designed for the purpose of GPs. Now, the thing about the ACGs versus the CPGs as well is that CPGs were originally written by the clinicians, and then the MOH would then edit it for consistency of format. But what we were finding was when the consultants in the hospitals, as you know, are very busy people, and often it would be very difficult for us to actually get the submissions in on time, particularly with controversial subjects. So one example was the lipid guidelines that actually took 5 years to develop, by which time much of what was written 5 years before was already sort of obsolete by the time the guideline was supposed to go out. So, after that, ACE changed it, MOH changed it to the ACE ACG format, where you will notice that what we send out to you is actually far more concise. It's very practice and practical focused, and it normally takes us 6 to 9 months to produce. And this is actually produced by staff who are trained specifically in guideline development and evidence synthesis, and then it is run through with a panel of experts to ensure that this is in line with local practice in Singapore. So that's the difference in methodology. In 2018, Dr. Tan Cheo Heng joined MOH as a clinical fellow, and we wanted to work on a joint project together, and we were looking at areas where we think that there is a lot of wastage in care, right? What I mean about wastage in care is things when we perhaps spend a lot of money on investigations or on treatment, but where the returns are relatively low in terms of clinical outcomes. Okay. I see this in my own field, which is endocrinology. I see that, in recent years, I don't know whether you've all noticed that the free T4 TSH test now, the rate of abnormal results is actually quite high. And part of the reason is that, I think at least, is first of all, the way the new tests actually have certain refinements that make them technically superior, but also clinically more difficult to interpret. And also, a lot of people nowadays take biotin, right, for their hair, young women in particular, right, or maybe older women as well. And the thing about biotin is that it interferes with the thyroid hormone assay. So you actually see a very high amount of, relatively high percentage of abnormal thyroid function tests, where previously we didn't see them. So you get a normal or high free T4 with a normal TSH, which are, all of you as doctors know it shouldn't be what is happening. If you get a high free T4, your TSH is supposed to be low. So when you have a high free T4 and normal TSH, this suggests the possibility of a pituitary tumor that is secreting TSH. Now, 99.999% of the time, this is not the case. This is just an assay problem. But what happens? because it's hard to interpret and you want to cover yourself, you order an MRI pit, which is not required, right? And so this is an example of a testing problem causing a very unnecessary investigations which drive up costs and do not in any way improve clinical outcomes. All right? So I think when we were talking to Cho Heng, we're trying to find certain areas in radiology where we find that the yield is very, very low. That means to say that, you know, the clinical, maybe symptoms or culture or certain tests drive the need for, say, certain radiological procedures, but the yield from those procedures is extremely low. And this is when Cho Heng, and credit to Cho Heng and his colleagues, they worked on this for 5 years to develop Acuity. And we have some of the key members here today who will be on the panel to share with you all the work that has been done in this space. It was a very difficult project to do, and I commend the team for taking it to where they have. And so, once again, I want to thank the team members who were involved in Acuity, as well as all of you for joining us today. And I'll just hand you over to Cho Heng now. Thank you.
Thank you, Dr. Koo. Today, we are honored to have with us experts in the field of headache assessment and management. To start off, let us welcome Associate Professor Tan Sher Heng, who serves as Assistant Chairman Medical Board, Clinical Research and Innovation, and Assistant Dean, Clinical Research for the Lee Kong Chian School of Medicine. As Acuity's project lead, Professor Tan will be briefly sharing about this project. Professor Tan, please.
Yeah, thanks very much. Yeah, sorry, I think we are mostly kaki lang, right, from our local practitioners. So I'll try to make this slightly less formal. But thanks very much for the kind intro, and thanks, Daphne, for the kind of brief background to Acuity and the efforts. Actually, a lot of contribution by Daphne's team who are familiar with guideline formulation, and I think I personally also benefited a lot from the experience. So I want to share with you what Acuity means, and I need to do this in 5 minutes. I also need to get you on board for the polling and then to introduce the speaker, so I'll probably have to rush through this. But as Daphne alluded to, I think there is often that concern about overconsumption of healthcare resources. We know that imaging is a vital aspect of the diagnostic toolkit for all of us, but it needs to be used judiciously, primarily because of cost, but also because many times all these unnecessary imaging lead to further unnecessary follow-up, either imaging or even biopsies. So the intent of this project was really to formulate guidelines for best practice, actually based very much on international consensus, contextualized to our local practice, and then of course we need that consensus from our local community, and this cannot be a radiologist-driven approach. It needed to encompass the inputs of all the key people or key specialties that were referring primarily these studies to the radiologists, so we had relevant representatives from different AMS colleges. As Daphne alluded to, we were looking at the high volume and high impact kind of imaging studies to try to prevent overutilization. So over the course of the last coming to 3 years, we were actually publishing over time the consensus guidelines, and these actually are branded under the MOH ACE clinical guidance. So documents specifically for MRI for low back pain in late 2020, and then when not to order chest x-ray in 2021, and then last year in August, we finally published the headache one. I must explain that the headache one was in many ways really a headache for all of us, because it's actually a very complex topic, and we were trying to make it something practical and easy to use, but at the same time also reflected best practice. And actually, it didn't take us 5 years to come up with this. It's a lot shorter than that, but I think in different speeds depending on the complexity of the guideline. And I think I would just mention that, you know, kudos to Daphne's team for working with us, and actually all the work group members who actually so volunteered their time and expertise despite COVID. So we were having meetings virtually over email as well as on Zoom. And just to share the impact of the Acuity, is not limited to just formulating the guidelines. We were looking at implementing the low back pain, MRI for low back pain. So if you go to the public health hospitals, you will see that when the clinician orders MRI for lumbar spine, there's a drop-down list that indicates the ACE clinical guidance. At the same time, for the chest X-ray one, we have rolled it out in NTU. Actually, we have sent this message out through MOE. So the pre-enrollment checkups, where chest X-ray for local asymptomatic individuals is unnecessary. So over the last 2 years, actually, we've avoided more than 11,000 unnecessary chest X-ray. And actually, we are kind of figuring out for the rest of the autonomous universities in Singapore as well. So there is real impact. And I think we are at the last of the 3 guidances, and we are trying to first start with increasing awareness generally for everyone to be familiar with the guidance, and then later see how we can also kind of hardwire this into our local practice. A very quick one on this particular guidance. I did share with you that it was a headache. I think as later on when you hear from our experts, you will realize why it does get a little bit complicated. And I'm actually looking forward to the Q&A because I believe it will be quite an interesting discussion. We know from data that for CT and MRI in our local practice to radiology, right, that referrals for MRI and CT brain are among the highest in volume. And there is also a well-established and a large body of evidence. And actually for this guideline, we did refer to quite a number of the international consensus guidelines and statements on the appropriate use of imaging for investigation of headache. And I think later Choyson, our neuroradiologist, will also share with you some nuances between CT and MRI and how they can play complementary roles. So when to order the CT, when to order the MRI, and when to use IV contrast and so on. And so here is the work group members. 4 of them are here, but we also have others, including Francis Lee, who is an emergency physician from Khoo Teck Puat, Vincent Ng, who is a neurosurgeon from NNI, as well as David Lok, who is an ENT surgeon from KDPH. And I'll introduce the other speakers in a short while, but you will see that they come from a diverse range of specialties, also different clusters representing local practice in the different settings. So today we are very privileged to have 4 of the work group members here with us as speakers, and Bernard is the chair of the committee. He's a neurologist from NUH, and he's the one really driving a lot of the academic discussion behind the guideline, and his partner is actually Yasmin, who is also a neurologist, but from NNI, and so they work in slightly different settings, but very much clued in on the latest on headache management. Choyson is a radiologist from NNI, so he comes from the perspective of a radiologist sharing his inputs on where CT and MRI is relevant. And then Gilbert is a family physician, so from the primary care, and he is the one giving us a lot of the insights on how this guideline can have some implication or impact on the primary care side of things, and how do we word the guideline document so that it's relevant to everyone. We have 3 questions. The first is, what is your profession? Though I'm getting a sense that probably most, if not all, of the participants today are doctors. Yes, we do have some nurses as well. Sorry if I seem to have kind of biased towards the medical side, but yes, it's great to see we have nurses and also from the other healthcare professions. I'll move on. The second one is, what is your practice setting? And it kind of gives us a sense also of who we have managed to create awareness today, from which sector. So is it the private primary care, which could be private or polyclinic, and then the hospitals, and then the intermediate long-term care, or others? Yeah. Okay, this is the result. Slightly higher proportion in GPs, private GPs, and then slightly more than half from the public sector. Okay, and then how many years have you been practicing? We're not going to figure out your age from this. We just need to get a sense of what the rough experience level is among the audience. And actually, I'm already falling into the more than 20 years category, so I'll join you guys right after this. Yep, okay, so we have a fairly mature audience in terms of experience, which is great. And then hopefully the discussions will be even more robust later on. Okay, so without further ado, let me introduce our first speaker, Dr. Bernard Chan, who is Senior Consultant from NUH Neurology, and he's actually the chair of the work group, and he's the one with the most headache trying to come up with this guidance document, and he will be sharing on the principles for comprehensive headache assessment. Dr. Bernard Chan, please.
Thanks, Chair Heng, and thanks, Dr. Koo. So I'll just, without further ado, I'll just go to the my talk. Okay, we go to another polling question. How confident are you in deciding when to order CT or MRI for headache? Few seconds. Not confident, slightly confident, somewhat confident, or completely confident, or you're not. Okay. Okay, I think not really bad, huh? It's actually quite confident. 39 participants, okay. Okay, maybe I go to the next one. Okay, this is a 32-year-old female teacher reports having headache since she was 18. It is occipital, generalized, throbbing, severe and lasting the whole day. She also had nausea and photophobia. She usually gets these 2 to 3 times per month. How likely are you going to order a CT or MRI for this patient? 0 is extremely unlikely, and 10 being extremely likely. Okay. So let's see how many have voted. Okay, a lot have voted already. Okay, the results are quite gratifying. So second question, 65-year-old man who has been smoking 20 sticks per day for the last 45 years, developed a gradually worsening headache with nausea over the last month. He also had a chronic cough and dyspnea, weight loss of 5 kg over the last 6 months. So this one, how likely are you going to order a CT or an MRI? 0 being extremely unlikely and 10 being extremely likely. Okay. So let's see the votes, 36, 39. Okay, I think most of you have get your votes, okay. Which of the following headache conditions, this is my question actually, okay, so this maybe we spend some time in discussing. So it's actually a different headache conditions in subjects with otherwise normal neurological examination, okay, and which of them requires the most urgent neuroimaging? You choose the most urgent one. First one is associated with a Horner syndrome, ptosis and a small pupil. Second one is a very severe headache, reaching its maximum within seconds with vomiting, and this is the first time. Third is a headache, increasing headache frequency and severity with a known history of migraine. So it's a change, somewhat a pattern change, although he has migraine. And fourth is the first onset of progressive left-sided headache, and he's a middle age at 57 years. The last one is recurrent headache precipitated by cough. So every time he coughs, he has a headache. So let's see. Most of you have voted. And I don't know whether I put the answers there, but okay. Let's go back to it. And you're correct. The second one, very severe headache reaching the maximum within a minute and usually within seconds, and sometimes associated with loss of consciousness or vomiting, is what we call thunderclap headache. And the first we need to exclude is subarachnoid hemorrhage. So this is urgent. You need an urgent CT, need to go to the A&E. And let's go to the other choices. And I think the second one, I think in urgency, is actually associated with Horner syndrome, because you actually worry about carotid artery dissection. Sometimes they have neck pain, sometimes they have a history of trauma or connective tissue disease. And it is also possible to have vertebral artery dissection, but if it's vertebral artery dissection, usually it's because of lateral medullary syndrome that's causing the Horner syndrome, so there should be some neurological signs. And then with no neurological deficit, it's just dissection without a stroke, but we also want to investigate and institute maybe antiplatelet therapy to prevent the risk of having a stroke. The third one, 6% you choose is a progressive left-sided headache. Actually, I would rank this as the fourth, because the third one I would choose is recurrent headache precipitated by cough, because it suggests either a posterior fossa tumor, like a cerebellar mass, or what we call a Chiari malformation, because the cerebellar herniating down through the foramen magnum. So this one is not urgent, but we want to order an MRI. The fourth one I would rank as what you rank as the third one is progressive left-sided headache at 57 years. We worry about a tumor, okay? And it's one-sided headache. But of course, headaches are very common. We can also have tension headache, we can also have migraine headache. So sometimes, if otherwise the examination and the history actually suggests a benign headache, maybe we can actually treat first. Although, I would say, I also agree we might want to get an MRI. And of course, the last one is actually migraine. Migraine can exacerbate and change because of stress, because of patients' fatigue and other things. So we should actually treat first. And this one, I actually don't consider doing neuroimaging, at least in the initial stage. So to go on to my talk, we'll talk about the prevalence and the recommendations in the guidelines and some of the helps that we can actually try to remember these guidelines. So headache is actually one of the top cause disease burden in the world. And according to the Global Burden of Disease study that is published in 2019, headache is after low back pain, the third, but it's actually quite similar in burden to depressive symptom. And among the young patients, 15 to 40 years old, is actually the top cause in causing disease burden. And this is primary headache, so it consists of migraine and tension, but because migraine is generally more severe than tension, so most of the disease burden is actually because of migraine. So that's why in primary care we see a lot, and then we actually, it's actually worthwhile to investigate managing migraine patients. And in Singapore, a community study that was done in the past a while ago by Dr. Ho King Hee actually shows the lifetime prevalence of headache was more than 80%. So more than 8 out of 10 of us will have a headache at some time in our life. Point estimate for migraine is actually quite low, but it's actually because when they diagnose migraine, they have to satisfy a number of criteria, which Dr. Yasmin will go into later on. And some of them actually didn't fulfill the criteria that maybe they have to have 5 migraines and the migraine has to be over 4 hours. They're actually having shorter migraines. But in taking some other suggestive cases, the prevalence of migraine is actually higher, up to 10%. Okay, and tension headache, of course, is much more, 40%. What about the use of imaging? Sherhing and Dr. Koo said, okay, this is one of the areas that is overused. We don't have data in Singapore, but in USA data that was published a while ago, and this was quite widely cited, imaging was obtained in 12%, and even in migraine, okay, even the doctors diagnose migraine, they should not order neuroimaging, but even in migraine, they order, 1 out of 10, they order a scan. And neuroimaging has been increasing steadily, even in 2010. It was ordered in 15% of the patients. And what are the predictors that they order it? It's actually quite surprising. First visit to any doctors, a neurologist visit is actually associated with use of neuroimaging. This is like defense medicine. Patient come, okay, maybe the patient demands it, and then you don't want to miss anything, you just order it first. But it's actually incorrect because most of the patients we see are actually benign primary headache. It will be like, I'll show you, it's actually less than 1 out of 100 or 1 out of 200 that will be positive. So the cost of ordering a scan is actually out of the 200 patients that you obtain to have a scan. So the cost is actually $1,000 for an MRI or $500 in subsidized rate. You have to times 100 to find one pathological condition. And where's the red flags? That means if they have thunderclap headache, neurological deficit, papilloedema, history of cancer, and so on. These are red flags that would increase your chance of ordering a scan. It actually did not, okay? It actually slightly increased, but it actually didn't reach significance. So it is a bit worrying. And even in emergency, there's still 30%, over 1 in 3 in 2014 in America, they order a scan. Of course, in emergency, we have subretinal hemorrhage, we have stroke, we have head trauma, so that's increased the frequency, but still it's too high. And what about the positive finding, the chance that you can find a positive scan? This is a very well-cited old British study. 4% of the consults to the NHS GPs are new headaches. Among the primary headaches, that means you can diagnose tension or migraine. The chance of finding a malignant tumor is very low, 0.03% in young patients. Even if you are older than 50, the chance is higher, but it's still less than 0.1%. If you cannot diagnose migraine or tension, then the chance is higher, but it's still, in the age over 50, it's still less than 0.3%. In a more recent Chinese hospital case control study, that is hospital patients, so they have a little bit of higher rates, it's diagnosed around 0.6% in primary headache patients, okay, otherwise normal neurological examination. And all the abnormalities are found from MRI. So first, this rate is low. Second, if you want to do a study, do MRI because the chance of finding something is higher. And then there's another meta-analysis published in BMJ that shows that, okay, brain MRI in asymptomatic patients, the chance of finding something in adults is 1.4%, but only 0.6% were due to malignancy. And in another meta-analysis, it also shows another message. 17% of all the studies and 20 or more than 1/4 in MRI, you actually have some unexpected findings or normal variants, but most of them are actually inconsequential. White matter disease, maybe arachnoid cyst, maybe a very small meningioma, which doesn't really affect your management. And when you really want to find something significant like malignancies, glioma is actually very low. So the recommendation from different societies, for example, the American Headache Society, this consists of headache specialists in America, they recommend not to order any neuroimaging in patients who have stable headache that meets the criteria of a migraine, okay? And don't perform CT imaging for headache when MRI is available. If you want to do a scan, patients usually can wait and you do an MRI, not a CT, okay? I'll explain the reason why. American College of Radiology appropriateness criteria that we base our discussion on in this guideline, the latest in 2019, they also recommend new classic migraine or tension headache with normal neurological examination. Do not order neuroimaging. And chronic headache with no new features or no neurological deficit, you also don't order neuroimaging. So now come to the different recommendations in our guideline. First, patient with migraine or tension type headache without red flags. We'll talk about the red flags later on. Do not order. So you see, CT is not indicated, MRI is not indicated, so do not order. It's because of the very low incidence of finding anything significant. If you fulfill the criteria of migraine or tension type headache. Yes, we will go through the diagnostic criteria, but migraine is actually easier because you actually have unilateral headache, pulsating pain, severe intensity, nausea, vomiting, photophobia, phonophobia, and so on. Tension is a little bit difficult. You see the American Headache Society, they actually recommend not to order for migraine, but they didn't say anything about tension. Because sometimes people worry that tension headache in a middle-aged person may have a risk of tumor. So, and you see the tension headache criteria is actually a little bit amorphous. Bilateral pain, there's everything not migraine suggests tension. So that's why it might not be very helpful. So clinically, we usually consider other things like whether patients have stress, neck muscle tension, scalp tension, and those sort of things. And because tension is even more common than migraine, and if you order neuroimaging, it will be like millions and millions of neuroimaging of no avail. So I think you should think in this way. And repeated CT scan, especially in young subjects, increase cancer risk. Every time you go to a clinician, every time you go to a neurologist, to an ED, you have a CT scan. Then over years, you have a lot of radiation. And the third thing is, we know that incidental findings are very common if you do an MRI. So if you do, you get the MRI report, okay, chronic ischemic change, maybe arachnoid cyst, meningioma, you refer to neurosurgeon, you refer to neurologist, but these are actually quite benign, and you need to unnecessary anxiety and further costs. Second recommendation is, if you have cluster headache or other trigeminal autonomic cephalalgia, you might consider ordering an MRI, because these headaches are associated with these autonomic features like conjunctival injection, lacrimation, nasal congestion, eye edema, and so on. Yasmin will go through them. We have more conditions. The traditional one is cluster headache, which is like having one to a few times lasting an hour and so on. But you have other categories which have increased frequency and shorter duration. And they are traditionally and classically responsive to different treatments like cluster headache to oxygen and maybe paroxysmal hemicrania to indomethacin. So these headaches are associated with pituitary adenoma and some other base of skull lesion. So it's not urgent, but you can order an MRI. Then the third recommendation is if you have a thunderclap headache, that is sudden severe headache reaching maximum within a few seconds to a minute, you really need to order a CT scan because a CT scan is more easily available. It can actually exclude subarachnoid hemorrhage with high sensitivity within the first 12 hours. If you are still suspicious of subarachnoid hemorrhage and CT scan is negative, you actually go on to do an LP. So this is from medical school. Whereas there's also other differential diagnoses. If you have recurrent thunderclap headache, you have a condition called reversible cerebral vasoconstriction, RCVS, and then other conditions like arterial dissection, cerebral venous thrombosis, intracranial hypotension, pituitary apoplexy, and so on. So you need to discuss with a radiologist if the SAH workup is negative. The fifth recommendation, okay, now we talk about another recommendation that requires a CT. Okay, this is post-traumatic headache. Why we said a CT is necessary is actually CT is more sensitive to actually skull fractures and cerebral hemorrhage and so on, intracranial hemorrhage. So CT is actually the first study we want. And why? It's because in neurosurgery, there's a lot of guidelines on head injury. They divide into mild, moderate, and severe head injury by Glasgow Coma scale. So moderate and severe, you already need a CT scan. But for mild, there are two criteria. The New Orleans, you see, headache is one of the indications for CT, whereas the Canadian is a more conservative. They actually use other criteria. So because of that, we said maybe if you have headache, you actually want to have a CT. And then MRI may be indicated if CT is negative, you still want to find whether there's any other abnormality if the patient is still symptomatic. Okay, and of course, we mentioned before in the beginning, if patient has trauma, then arterial dissection or carotid dissection with suitable clinical signs and history is also another condition. Okay, then the other two recommendation 4 and 6 are actually for the red flags. First, we want to emphasize that patients with some history, that is, they have cancer or infection, or if they are immunocompromised, if they present with other evidence of suggestive of infection or cancer, then they might have meningitis, cerebral abscess, or brain tumor, or brain metastasis, or they have such history, and or if they are middle-aged or above with new onset headache. Of course, we have a discussion of this red flag, okay, because this age over 50 with new onset headache also suggests giant cell arteritis if they have scalp tenderness or loss of temporal pulse on one side. And this condition is actually not diagnosed usually by neuroimaging, it's usually by examination and history. And of course, we do physical examination and we try to find the signs and of systemic cancer, infection, or neurological deficits, or papillary edema. Okay? Then the other recommendation is just to lump all the other red flags together. If you have red flags, then you also maybe, and these conditions, whether you have cancer or infection or red flags, we usually recommend MRI over CT because MRI is more sensitive, unless you are in an urgency, patient is in the ER, you have acute meningitis, and so on. So one is positional headache. Patient has headache when they get up. The headache is relieved when they lie down. This typically occurs after lumbar puncture or epidural anesthesia. They have a CSF leak, so they might not even do a neuroimaging. They might just do a blood patch by the anesthesia, anesthetist to treat it. But if they don't have a history, then you might need to do an MRI to find the source of a leak and to confirm the diagnosis. Idiopathic intracranial hypertension is pseudotumor cerebri, usually occurred in female, obese, they have papilloedema, they have headache. They are less dependent on posture, although with increased intracranial pressure, they have headache when they are lying down, but it's less prominent than the positional change compared to the low pressure headaches. These you need MRI for diagnosis. There's cough headache we mentioned early on in the pooling question, which suggests posterior fossa tumor or Kyrian malformation. But there's another type of headache associated with exercise or sexual activity, and we can consider sexual activity as a type of exertional headache. So sometimes they present like a thunderclap headache, so we need to rule out aneurysm or subretinal hemorrhage. But interestingly, sometimes it's because of they have ischemic heart disease and they have decreased cardiac output, so they might actually have headache because of hypoperfusion to the brain or some referred pain from the chest to the heart. So you might also want to see whether the patient has any risk factor for ischemic heart disease. And pregnancy and postpartum period is actually high-risk period of several conditions like eclampsia, preeclampsia, this PRES, posterior reversible encephalopathy syndrome associated with headache and seizures is something like preeclampsia, stroke, and cerebral venous sinus thrombosis. Actually, in this setting, the chance of an abnormality with abnormal physical signs like papilloedema is actually quite high. So we consider neuroimaging much more highly in priority. And of course, there are other conditions, as we mentioned. Giant cell arteritis usually is diagnosed by clinical signs of temporal tenderness, loss of the temporal artery pulse, jaw claudication. We need to do ESR and CRP because some patients, 5% are negative in ESR, but if you do both, it should be 100% positive. And we ask the ophthalmologist to do a temporal artery to diagnose it. We usually don't do something like MRI vessel study, but the ultrasonographer or the radiologist can easily do an ultrasound and find what they call the halo sign, which is the thickened and inflamed arterial wall in the superficial temporal artery. Medication overuse headache is also mentioned in as one of the red flags, but it's actually primary headache. Usually migraine become chronic, and they are associated with overuse of analgesics, like potent analgesics more than 10 days per month, or simple analgesics, even paracetamol more than 15 days per month. It's like a dependence. The day that they don't take the analgesics, they will have the headache. So it's a very difficult condition to treat, but it's not diagnosed by neuroimaging. So just a few words about sinusitis. In the old days, we do skull X-ray, CT scan in patients who have sinus pain or sinus tenderness. But actually, migraine can present with sinus pain and can present with some nasal discharge. And simple sinusitis, you usually treat symptomatically with decongestant. And it's only in those who have bacterial infection that you might actually want to diagnose sinusitis. So the approach now has changed. We actually refer the complicated case to ENT. They may do a scope and try to find the prurient discharge and then treat accordingly. So CT sinus although it's one of the investigations, followed by MRI if there's intracranial extension, but it's actually not the first procedure that we'll use. So in order to remember all these red flags, we have this first proposed by David Dodick, the headache specialist in Mayo Clinic, SLOOP. Let's summarize for systemic condition or secondary disease, neurological symptoms and sign, acute onset like a thunderclap headache, older age more than 80 or more than 50, positional headache, prior history that there's a change in the history, and then a pregnancy, postpartum or precipitated by Valsalva. And more recently, this is the table we use in the guidelines, so it just expand those a little bit more and put in a few more P's, like a painful eye with autonomic features which suggest cluster headache. They put in post-traumatic headache. Painkiller overuse is not usually indicated for neuroimaging. So in summary, most headaches in primary care and even in specialist practice are migraine and tension type headache. And if they fulfill the diagnostic criteria without red flags, do not require neuroimaging. If neuroimaging is considered in migraine or tension headache, consider MRI over CT, except in emergency situation. Or maybe they have a venous sinus thrombosis or stroke or something like that. In patients who present with thunderclap headache or post-traumatic headache, CT is preferred. In most other headache conditions with reflex, especially the patient is rather stable and can wait, you would actually prefer an MRI. Okay? And you can use the SLOOP 4 or the SLOOP 10 mnemonic to screen for the red flags. Okay. Among the following headache patients, who do not require neuroimaging? Okay? Who do not require neuroimaging? First, associated with stuffy nose and sinus tenderness. Second, history of treated breast cancer 15 years ago. Third, migraine with daily headaches requiring analgesics and refractory to prophylaxis. Fourth, road traffic accidents with minor head injury 4 days ago. And fifth, generalized seizure today and history of delivery 2 weeks ago. I couldn't see the post here. First one, associated with stuffy nose and sinus tenderness, I would say not to order because, as we said, we first treat symptomatically and refer to ENT if necessary and not to do imaging first. History of treated breast cancer, I would do MRI because breast cancer can have late metastasis. Migraine with daily headaches requiring analgesics and refractory to treatment is like chronic migraine or a medication overuse headache, so probably you try to treat, stop the analgesics and give prophylactic treatment or refer to headache specialists. Road traffic accident with minor head injury, we usually need a CT. Generalized seizure today with delivery, this is a postpartum seizure. You might actually think of stroke, PRES, or cerebral venous sinus thrombosis, so you need a CT or CT and CT venogram. So it's the first one and the third one, we actually don't need neuroimaging. Thank you. So I think I'll pass the time to the second speaker, Yasmin.
Okay, thank you, Dr. Chan. Now let us welcome Dr. Jasmine Idu-Jion, who will be speaking on primary headaches, migraine, tension type headache, cluster headache. Dr. Yasmin, please.
Thank you very much for that kind introduction. So good afternoon. So today I'll be speaking on primary headaches, in particular migraine, because there's a lot more information that I think you guys need to know about migraine, followed by tension headache, and then very briefly on cluster headaches. We will be discussing assessment of headache disorders, which has been partially covered by Bernard, followed by clinical presentation of the primary headache disorders as well as management. So this is a patient that was covered in the poll, a young lady who's had headaches that are of long-standing duration. She describes them as occipital or generalized, throbbing, and associated with nausea and photophobia. If she gets them 2 to 3 times a month, I think we can all rest assured that this sounds very benign. Right? And if you think about the associated features, this would fit very nicely into the criteria for migraine. So you probably won't be very concerned about this presentation. But she changes her history, and now she says that this time the headache is a bit different. She has got fever, and she's been feeling under the weather for the last 2 days. So that makes you sit up a little bit. You worry about whether this could be an infectious or inflammatory cause, be it systemic or neurological. Or if she changes again and says that actually this is the worst headache that I've ever had in my life, I've known to have headaches for a long time, but this headache woke me up from sleep. It's really like a volcanic eruption. I'm very worried because my family member has got a bleed before. Then you worry whether this could be a vascular event like a subarachnoid hemorrhage. So as you can tell, the history of utmost importance in a patient presenting with headache. And unfortunately, it takes time to actually draw all these features out from a patient presenting with headache. So that brings me to the next slide. The ICHT actually came up with a 180-page document documenting the specific details and criteria for all the different headache conditions that are known to us. And they have divided this into part 1, which is the primary headaches, of which the commonest would be migraine and tension type. Part 2, which is the secondary headaches, headaches attributed to something else. It could be a vascular event, it could be a trauma, it could be substance abuse, etc. And then the last segment is on cranial neuropathies, of which the commonest is trigeminal neuralgia. So in assessing a patient presenting with headaches, go back to the history first. Take a very good headache history. So I don't need to remind you guys how to take a headache history. I think this is quite common. But what I find that in general, aside from asking about the character, the frequency, duration of the headaches, ask about the temporal profile of the headaches, ask about aggravating factors and triggers. Migraine in particular has very, very clear triggers. If you have hormonal headaches, almost 99% of the time it is actually migraine. Okay? Ask about associated features because like what Bernard has mentioned, migraine has got associated features, nausea, vomiting, sensitivity to light, sound, smell, etc. And ask about background headaches. Sometimes this question does not get asked enough. When a patient presents to primary care in particular, they are only concerned about the headache they are experiencing at this point in time. They won't talk about background headaches in the past. In fact, even if you ask them, they'll say, oh no, I've never had headaches before. But if you ask them, think back again. Have you ever had headaches in your life before? Maybe not like this, but something else. Then they will start to think back and you realize that they've had headaches for a long, long time. The characteristics may be similar or it may be different, but I think it's important to ask about background headaches because it changes your differentials. Red flags, so Bernard has mentioned the red flags before, so I'll just skip this part. I usually ask about what medicines they have tried and how much they use them, because this gives us insights on two important points. Number one, the pain threshold for the patient. Some patients just love taking painkillers. Okay, some patients don't. So I think knowing which category your patient falls into will help you to actually counsel the patient a bit better about treatment options. The second point it helps you is that it tells us the risk of this patient developing rebound headaches. So rebound headaches is also called medication overuse headaches, and it can be a significant problem, especially when the headaches are long-standing. And treatment for this condition is actually not easy. When they come to me in the clinic, I usually ask them about function. Has these headaches actually caused disability to them? So there are validated scales you can use, the headache impact factor test or MIDAS for migraine. Or you can ask them very simply, have you taken leave or been absent from work or school because you've got headaches before? The point is that if they have been absent for their chores or absent for their school or work, implies that this is significant disability. And last but not least, ask them about mood, ask them about sleep. These are two very important confounders that will affect headache. For sleep in particular, ask them about quality of sleep as well as quantity of sleep. Whether they've got problems falling asleep, staying asleep, whether they snore at night, whether they've got early morning headaches. And for mood, I always ask them about depression and anxiety symptoms. Of course, the headache history is nothing without the appropriate patient context, so always think about the patient context first, the age of the patient, if the patient is a female, which part of the reproductive life it's in, because this has impact on migraine management, as well as a medical history. In terms of physical examination, vital signs, in particular blood pressure, is very, very important. So obviously, it's given that we have to do a neurological exam, but don't forget your head and neck structures. Okay? Examine for facial tenderness, examine the TMJ joint, look for neck movements, feel the temporal pulses, do an eye examination. And then the optional thing is to examine the eye for fundoscopy. This is not easy given that it's a skill to be acquired. So basically, what's the algorithm like? Take a detailed history, do an examination. If there are red flags present, definitely you have to consider secondary causes and investigate appropriately. When I say appropriately, it doesn't equal to imaging. Okay, you can investigate using other things depending on what you suspect the cause could be. The next algorithm going down is you consider the primary headaches. So this is why knowing your criteria very well is important, because all the headache disorders, especially the primary ones, they are all criterion-based, meaning equals to history. So it boils down again to history. So if you're familiar with what is in the classic criteria, then you would be able to identify that this is typical feature or not. And if there are atypical features, then you have to reconsider secondary diagnosis as well. But if they are not, and you're quite sure that it fits nicely into the box, then most likely this is a primary headache disorder, and most primary headache disorders do not need to be evaluated. So going very briefly into migraine, in terms of epidemiology, I think Bernard has alluded to that prevalence of migraine in Singapore is about 9-10%. Half of these patients have headaches a few times a month, okay? So 4 to 5 days in a month. That is quite frequent. 2/3 of the patients actually miss school, work, or chores because of their migraines. More than half these patients have anticipatory anxiety, meaning that they worry about when their next attack could be, and they may or may not make life changes because of that. Depression is also 4 times more common in patients with migraines compared to controls. So this is based on a community study that was done about 20 years ago. A more recent study, this was published in Straits Times in 2018. So migraines cost Singapore $1 billion in 2018. And this is a study looking at episodic migraine. It's not even chronic migraine. So episodic migraine means headaches less than 15 days in a month. 80% of this cost is derived from loss of productivity, okay, because they miss work. 20% is due to direct healthcare costs. And out of all those with direct healthcare costs, 40% is unnecessary tests for migraine. So it's a substantial amount. Why is it so substantial? It's because migraine affects people in their most productive years of their lives. So between the ages of 20 and 50. Okay, it affects women 3 times more than men. In Singapore, the mean age of migraine is about mid-20s. Okay, but it's kind of like a bimodal peak. It starts off maybe in the late teens to early 20s, and there's a second peak in the late 40s to 50s. So it's bimodal in etiology. In terms of comorbidities, there is a high association with depression, anxiety, insomnia, other chronic pain syndromes like lower back pain, rheumatism, arthritis, and this has implications on treatment as well. Pathophysiology of migraine, I won't bore you with the details, but essentially it is a complex disorder affecting both nerves as well as vessels, and it works in the trigeminal vascular system. And what happens on a molecular level is that all these sets into series a cascade of changes in both the nerves, resulting in premonitory changes, auras, prodrome symptoms, as well as vascular changes resulting in headaches as well. So migraine is more than just a headache, okay? So typically there are 4 phases of a migraine attack. Not everyone has all 4, and sometimes each attack can vary from to the next. So you've got premonitory symptoms, meaning that they know that the headaches are coming on. Some people may feel tired, they might feel thirsty, they might yawn, or they may have GI discomfort. About 20-30% of patients have auras, which are transient neurological deficits, and these are usually stereotypical with each attack. Then you've got the headache phase, which can last anything between 4 to 72 hours. And even after the headache settles, there tends to be a prodrome. They feel hungover, they're not back to normal. So the whole entire process sometimes can drag for days. So while you have a patient with usually family genetic history, diagnosis of migraine, unfortunately, is just purely clinical, and there's no reliable biomarkers for migraine, meaning there's no diagnostic test that's available to diagnose migraine. Criteria for migraine, again, just briefly to mention, it is a condition of recurrent attacks, meaning you cannot diagnose migraine based on 1 or 2 attacks. You need recurrent episodes of attacks, and usually these episodes are what we call stereotypical. They feel about the same. The patient knows what is normal to them and what isn't. The headaches are usually severe, moderate to severe. They are usually unilateral, although they can be both, bilateral as well. They are usually of pulsating or throbbing quality. And usually any activities or work can aggravate the headaches. During the headaches, usually they will have either nausea or vomiting or sensitivity to light, sound, or smell. Okay, but sometimes there's a lot of questions to ask for primary care when you're staffed for time. So there is an ID migraine screener that you can use in your practice. It just boils down to 3 questions: whether the patient has got nausea, whether light sensitivity is an issue, and whether the headaches cause disability. So if you fulfill 2 out of these 3 criteria, the positive predictive value of actually diagnosing migraine in a patient presenting with recurrent headaches in primary care is actually quite high, 93%. So migraine with auras are transient neurological deficits, mostly visual, sometimes sensory, but you can get other kinds of auras as well. But what is important about auras to distinguish it from other differentials, including TIAs and seizures, would that these auras need to fulfill very strict criteria. So this is why it is important to know what your criteria are, because if they don't fit into this criteria, then you have to think about secondary causes. So the important aura criteria are, number 1, the auras have to spread slowly over time. It's not something that appears very quickly. They spread over a period of at least 5 minutes. It can last as long as an hour. They usually come together with or precede a headache. And sometimes when you have more than 1 aura, one of them have got to be unilateral. Okay? So of course, bearing in mind the context of the individual patient, also take due diligence into consider other differentials as well, particularly TIAs in the right context. So this is what visual aura looks like. It's usually a combination of what we call a positive phenomenon, flashing lights, zigzag signs, or you can have a negative phenomenon like a scotoma that usually evolves over time and space, and it usually spreads at a particular rate because of the way that the cortical waves are actually spreading over the different parts of the cortex. So going into treatment of migraine. So as with any pain condition, there's two ways to treat it: stepwise manner or stratified. Stepwise means for milder pain, use milder analgesics, whereas stratified means for the very bad ones, you attack hard from the start. Okay? So you can use a combination of both for the same patient. It kind of depends on the pain threshold of the patient as well. So that's why actually understanding how much the patient uses medicines and how they use their medicines actually is quite important. So I like to use fast-acting NSAIDs, and I usually combine it with an antiemetic because in migraine patients who've already got a lot of nausea, antiemetics help with the absorption of painkillers as well. Step 2 would be specific anti-migraine drugs. So you've got triptans. Commonly used ones would be sumatriptan, zolmitriptan, alittriptan. Then you've got your ergot drugs as well. These are your ergot with caffeine combination therapies. So it will be things like Cafox, Cafagot. And upcoming, I guess that will be coming soon in Singapore, would be the newer treatments, which is your CGRP agonist, antagonist, as well as your ditans, which is your 5-HT1F receptor blockers. Sometimes when this doesn't work, we combine treatment. So it's actually very important to review the compliance and the manner that the patient takes medicines, because for migraine, if you treat them early, especially in the first 30 or 60 minutes, the response rates tend to be so much better. Okay. One more thing to mention, opioids, usually we try as much as we can to avoid. And the reason why this is so is that it causes a risk of dependence to the patient. And they're not really very, very effective for migraines anyway. And it actually exacerbates the nausea that the patients are having. So this is a list of what analgesics are available. The last column represents parenteral medicines that sometimes you can use for the patients with very, very prominent nausea who might not be absorbing oral medicines very well. So IM or IV formulations are actually very useful in that manner. Antiemetics, I like to use metoclopramide, but you can also use prochlorperazine as well as domperidone to add on with your simple analgesics. So that's the first step, treating of the acute pain. But there's also a second step in migraine management, and that is prophylaxis of future attacks. So what prophylaxis means is that you give the patient regular medicines with the aim of ultimately reducing the pain frequency and intensity over time. But this is very important. It is over time. It is not instant. So when we give patients prophylactic medicines, we have to set the expectation that they have to persist with the medication, as effects only take place in a couple of months' time. So if the patients feel that there's no improvement in 2 weeks, they cannot just stop the medicine and say it's not working. They have not really given the medicine enough time to work. So when do we need to prophylax? So a few criteria here. If you've got frequent enough headaches, and this is something that you need to counsel and discuss together with patients. For most patients, having a headache a week is not too bad. They would rather not take regular medicines. But for another patient whose attacks are very disabling, even 2-3 headaches a month can be significantly bad enough for them to want to take regular medicines to prevent future attacks. Sometimes when they have frequent enough headaches, they find that the use of the acute analgesics are no longer very useful for them. This is another situation where you have to consider using prophylaxis. This table was taken from the American guidelines. This was published in 2012. Not much has changed since then, with the exception of maybe newer therapies that have been coming up over the last 3 years or so, CGRP monoclonal antibodies, and the upcoming CGRP antagonists. Botox has been used for chronic migraine, only in chronic migraine and not episodic migraine. But out of all the medicines in this table, only 3 big groups I think will be useful to consider and remember. First big group, beta blockers. Okay, very useful, beta blockers. Second big group, anti-seizure medicines. And the third big group is your tricyclic antidepressants. Very useful, and I think if you use one of the 3, majority of your patients will actually improve. Which one do you choose? Actually very much patient-dependent, depending on patient context, past medical history, comorbidities. But regardless of what you choose, you have to tell the patients that it takes time to work, they have to persist with it, and sometimes you have to wait as long as 6 to 8 weeks to see some benefit, and you have to maintain the treatment for as long as 4 to 6 months. We start low, on the lowest dose possible, and then we titrate up according to tolerance as needed. So these are the commonly used drugs, first-line drugs. Propranolol, starting dose usually 10 milligram BD, very well tolerated at low doses. Some patients get a bit fatigued, a bit dizziness. Amitriptyline and nortriptyline, my favorite, because it helps with patients who cannot sleep. The main downside is sedation, of which I find that nortriptyline actually is a little bit better in that area. Topiramate and valproate, they are anti-seizure medicines. I think not everybody may be comfortable prescribing anti-seizure medicines, but I find that topiramate is actually very, very helpful in patients with migraine, and it's got one of the best efficacy rates among all of these, yet the expense of very bad side effects. So it comes with a give and take. You have to weigh the risks and benefits for every patient. Valproate, we always avoid in women, simply because of the fear of pregnancy, and valproate is very, very highly teratogenic. So migraine is actually a dynamic fluctuating disorder. It can vary over the course of a person's life. Younger days, later on adolescence, and then during work, then during retirement. And then for women, you've got the hormonal changes in different parts of a woman's life as well. But essentially, once you have regular headaches, frequent enough, and this is usually more than maybe 8 to 10 headaches a month, there is very, very high disability rates. Okay? And once you have very high disability rates, and it increases over time, what happens is that there tends to be structural brain changes that start developing in your head. Once you have structural brain changes, you get chronic sensitization, central sensitization, and this means that you're just more predisposed to having perpetuating headaches, and once you hit a stage of chronic headaches, chronic migraines, chronic daily headaches, it becomes so much harder to treat. So we have to treat before they actually reach that stage. Over time, the thing is that sometimes these migrainous features also disappear. They're not so clear-cut anymore. They may not be that nauseous, they may not have so much sensitivity to light and sound. Over time, as the brain becomes chronically sensitized, these headaches become what we call as featureless headaches, which makes it very difficult to try and determine whether or not this is migraine or not. So what are the risk factors for this transformation of migraine from episodic to chronic? Some risk factors you cannot change, but what you can change are the two big ones there: attack frequency, which is why use of prophylaxis is very important, and medication overuse. These two alone account for risk of transformation by over 20 times. Okay? So medication overuse headache. So basically the headache has worsened, all right, in the setting of a patient who is overusing analgesics. And usually when you stop that, the headache reverts back to its original frequency. So how much is too much? So in general, depending on the type of analgesic you use, if you use them more than 2 or 3 days consistently in a week over time, that is considered too much, or this is considered medication overuse already. So what do? You have to educate them from the moment you see them. Okay, especially those who are taking regular analgesics as though they're taking regular vitamins. Okay, there's a large proportion of patients who are actually doing that, thinking that this is normal. That's not normal. Okay? The other thing you can do is to start prophylactic treatment. Okay? Any prophylactic treatment will do, but the best evidence comes from topiramate or Botox. Okay? But anything will do. And then you have to tell the patient you have to stop what you're doing. You have to detox yourself. You can do this in a variety of ways. You can tell them just one day, just quit cold turkey. Most patients don't like that. What you can tell them is, okay, let's do this together. Let's just try and reduce every week by half a pill or 1 pill, and then see how they go from there, which tends to be more appealing for the patients. Obviously, you try and tell them you have to manage your pain in other manner, aside from pill popping. And a lot of times, they have trouble actually coping with the pain, but this tends to actually get better over time. And sometimes it can take 2 to 4 weeks before the withdrawal symptoms actually disappear. So when you have a patient with migraine who still remains poorly controlled, then you have to think back, why is this patient not responding? So think about inadequate therapy. Commonest cause, because the patient's taking too low a dose. They're not taking for a sustained period of time. They give up after 2 to 4 weeks. They're just not taking the medicines. And some of the reasons they're not taking the medicines is that they either forget or they've got side effects. So compliance is an issue. So you have to educate them at the outset that this is the expectation. You have to be compliant to your medicines and persist and give it time. Second big reason is because of unrecognized or persistent exacerbating factors, okay, usually in the sense of medical or psychiatric comorbidities. If they have depression and anxiety that's not adequately treated, the headaches are not going to improve. Similarly, if they've got lifestyle factors, they're not coping with stresses very well, they're having very, very bad sleep, they're not really sticking to a particular routine, they're not going to improve very much either. So address these things as well. Last but not least, medication overuse. If they're still overusing medicines, you have to tell them, no matter what you do, it's going to be suboptimal because you are essentially sabotaging yourself, not allowing medicines to actually take full effect. So what do we do in these patients? We don't just tell them and then expect them to comply. So we help them along the way. We can give them combination treatments. We can try non-oral options. We can give them a more detailed plan for detoxification. But regardless of what we do, it's always talking to the patient because this is a partnership. If the patient doesn't trust you, you also don't trust the patient, then the partnership is lost. And unlikely the patient will actually return to you and they will continue suffering. Non-pharmacological strategies for migraine. Essentially, migraine brains, they love routines. Any deviation from routines they don't like is a trigger. Okay? So sleep-wise has to be fixed timing, make sure quality is good, meals, try and not skip meals, get them active, get them to cope with their stresses better, identify triggers and avoid them if that's possible. But sometimes this is not possible. A very brief mention on status migrainosus. This is prolonged acute attacks of migraine, where the pain or the associated features are actually very debilitating, particularly the nausea, the vomiting. So if they happen to come to your clinic at this point, try and give them a parenteral medicine to try and break them out of the cycle. Sometimes you can give them a short course of oral medicines. It could be in the form of steroids or antiemetics or muscle relaxants, a very, very short course. If they get admitted to ED, a lot of times they get IV treatment, or they get admitted, then they get a whole cocktail of treatments. But essentially, most migraine patients, they don't really like the emergency department because number one, wait time very long. Number two, it's very noisy, they hate noise. It's very bright, they can't rest. So migraine patients, as much as possible, try and treat them outside of the emergency room and hospital. And very important, other than that headache, start them on prophylaxis because it makes a difference. A very brief mention on menstrual migraine because I know women get migraine a lot more than men. And menstrual migraines are different from your regular migraines because they're more severe, okay? They last longer, and they are more disabling. Okay, so there are different types of menstrual migraine, but essentially you can manage them a bit different. For a lady who's got regular cycles, they know when their headaches will come. You can tell them to take a short course of medicines around that period, and that helps them. Or you can start them on regular prophylaxis as well. There's also a role for hormonal treatment, but usually they don't need to reach this stage. Migraine in pregnancy, a big headache to manage. Fortunately, most patients get better in pregnancy. Okay, but they only get better in the second trimester. Because first trimester, they're already so tired, so weak, they're vomiting. So it kind of worsens things. But second trimester onwards, most of them do get better, with the exception of migraine with aura. This one is a bit more inconsistent. Unfortunately, treatment for patients, with pregnant patients, is that a lot of our medicines are not 100% safe in pregnancy. Most are category B, category C in pregnancy. NSAIDs are only safe second trimester onwards, and you have to avoid them after, I think, 30 or 32 weeks. You can give an antiemetic, that's generally safe, and paracetamol. And there's a small registry that says that sumatriptan in general is safe. But again, that registry is not very big. Okay, coming up to the last few slides here. Tension headache, I won't really talk so much because it's what migraine is, not. So it's what Bernard has mentioned. You've got all the criteria that migrainous features: sensitivity to light, sound, nausea, vomiting. Tension headache doesn't really have any of that. And the duration of tension headache can be very short. It can be as short as maybe half an hour, an hour. It can last very long. It can last for days, even longer than migraine. Okay? This is what we call a featureless headache. It doesn't really have any special feature. So in that sense, tension headache is, I think, a bit harder to diagnose. Unless you've got a patient who's got tension headache for a long, long time, and it has remained about the same over time, then because of the benefit of long period of time that the patient has gone relatively well, then most likely there's a primary headache. But I think in the setting of a patient who comes in with tension headache features, that's quite short. It can be very difficult to actually diagnose tension type headache from the outset. Treatment-wise, I think less evidence-based because not many people want to study tension headache, so if there's a lot less guidelines on this. But again, the concept is the same. If you've got frequent enough attacks, more than maybe two attacks in a week or so, try and give them prophylaxis because you don't want them going into that habit of overusing medicines and going into rebound headaches. Cluster headaches is one of the headaches in this category, trigeminal autonomic cephalgias. So what it means is that you've got pain in the trigeminal distribution, all right? And it is usually side-locked, meaning it's one-sided. It doesn't switch sides like migraine. Migraine, you can have right side, left side, both sides, at the back, at the front. Whereas for TACs, it's usually just one side, it sticks to it, okay? And they are associated with autonomic features. So which autonomic features? Usually in the sense of lacrimation or tearing of the eye, runny nose or stuffy nose. They might get a feeling that their ears are a little bit blocked. They may get a bit of ptosis. Or some of them may not have that prominent autonomic features, but they may feel very, very restless. They cannot keep still. So this is also another criteria for attacks. There are many in this category, of which cluster is, I think, the most popular one. But they range in terms of the duration, lasting from seconds, all the way down to continuous, meaning present there 24/7 a day. So I don't think you really need to go down to the exact diagnostic criteria, because I don't think it's that common, first of all. And second of all, I think all TACs should be managed at a specialist level. That shouldn't be managed in primary care. So management, just very briefly for cluster, high-dose oxygen works for acute attacks and parenteral triptans. In terms of prophylaxis, it's a bit different from migraine. So you give verapamil, which is first line for cluster headaches. There's also used for other prophylaxis agents, such as melatonin, lithium, or even verapamil. But these medicines take time to work, and because the attacks are very disabling, we usually give them what we call transitional treatment, which is either a short course of steroids or a nerve block. So going back to the ACG, so that's why it's actually very important to know the diagnostic criteria, particularly for primary headaches, because a lot of the headaches that you see will be primary headaches. And most primary headaches, fortunately, don't require further investigations, okay? But there are several caveats. First one, if they are progressing despite optimal management. And what do we mean by optimal management? Meaning you're giving prophylactic therapy adequately and you are managing their accessibility factors, lifestyle, medication overuse, etc. And, or if they develop new symptoms or new red flags, then definitely there is role for investigations. So this comes under recommendation 6. Second recommendation is under TAC-like presentation, your trigeminal autonomic cephalgias. These patients should be evaluated and investigated because you cannot tell primary TAC from secondary TAC. They are indistinguishable. And the third one would be headaches that are triggered by exertion, Valsalva maneuvers such as cough, such as strenuous activities, because sometimes these can be present in both primary and secondary headache disorders, and you have to do imaging for this. Okay? So I think that brings me to the end of my talk, and with that, I think I thank you.
Thank you, Dr. Yasmin. So we would now like to invite Professor Choyson Lim, who will speak on choosing between CT and MRI brain, use of contrast or other modalities. Professor Choyson, please.
Thank you very much. Today I'd like to talk from the radiologist's point of view and review some of what we have been discussing, the differences, the similarities between CT scans, MRI. I also draw your attention to what is not going to be covered, because we're assuming that these are ambulatory outpatients coming from primary care situations and not from the inpatient wards or the ED, or they might be sent ambulatory to the emergency department. And that there are outliers to everything that I have said. So there are exceptions. Those are, I see. Those are some of the broad rules of thumb, but no rule is 100% without exceptions. So here's a picture of what a CT scan looks like. It's a bright and cheery donut in a well-lit room. Here's a picture of an abnormal CT. Conversely, this is an MRI scanner, a dimly lit, quiet room which has the background of a machine always going because it's never turned off. It's a long, dark tunnel, and patients may be frightened of the claustrophobia within. Here is what an MR image looks like. There are advantages and disadvantages associated with both investigations. You can imagine that the advantages of the CT are the disadvantages of the MRI. The reason why we have to be careful about ordering tests is that there is a potential for harm in both CTs with radiation and with MRs with the risk of pacemakers and other conditions, implants and surgical procedures that disqualify either absolutely or relatively a patient from an MR examination. So for instance, a pacemaker used to be an absolute contraindication, flat no, you get rejected from the MRI, please go to the CT scanner. However, because of advances in engineering, there are nowadays MRI-compatible pacemakers which can be safely carried out into an MR scanner. So many of these things are changing. That's why I mentioned that these are just rules of thumb. CT has radiation, whereas MRI does not. And the importance of this means that women of childbearing age and young children who are developing and women who are pregnant, CT is either absolutely or relatively contraindicated. We would prefer MRI. And that's why in pediatric populations, we depend a great deal on MR scanning compared to CTs. Both are extremely versatile. CT is the best thing since sliced bread and allows us to look inside the body, not just in the brain, but everywhere else, very quickly and very expeditiously, very good for trauma and emergency situations. MRI is a little bit more complicated, but has certain advantages because the biomarkers are much higher in MR scanning. And I'll show you some examples in a minute. Both can be combined with angiographic, venographic, perfusion, and today there are scanners that can combine CT with positron emission tomography, PET, or MR with the same. So engineering has led to a lot of these things which are not directly relevant to today's study, except to note that angiographic studies do have a role to play in certain types of headaches, not necessarily in the first blush of primary decision-making on whether the patient has a primary headache or a secondary headache, but in the later subsequent investigations. So this is what I meant by MRI takes into account multiple biological features in the brain. It takes into account the movement of water, flow of blood, and the presence of blood and calcium. Each one of these individual pulse sequences looks different. The abnormalities will be very different, and radiologists go through a ton of training just to make the differences, as well as to try and push the frontiers of what can be seen in the future, but which is not seen today on conventional MRI. As you can see, this is the slide that I teach medical students and trainees. There are many ways to try to make sense of these pictures, and MR is extremely powerful. I'd like to reiterate that safety is vitally important. The risk of referring a patient for investigation to do an MR or CT is not zero. There are potential harms, ranging from pacemaker malfunctions, radiation effects, contrast reactions, and therefore we have to weigh the risk-benefit ratio very carefully. There are contraindications to CT, as I have pointed out. Contrast is very important for many types of headache. And if we are performing CT angiography or CT venography, contrast is automatically included in the process. For MR, safety is even more of a big deal. There are warning signs, red lines all over the place because of the mechanical effects of a strong magnetic field that is never turned off unless something terrible has happened. There are also functional effects on pacemakers and other devices that are continually being added to the toolkit of our surgeons and our doctors. So therefore, if there's a patient with an implant in any part of the body, not only the brain for a headache study, any part of the body, information on the exact brand, model, and type would be very important in the safety screening for MRI. All patients must pass through that. I think it's even stricter than airport security. We want to prevent a terrible incident such as this from a newspaper article, and this isn't the only one. This isn't even the latest one. This resulted in a fatal outcome. Other less injurious or non-fatal outcomes also lead to terrible consequences and tons of paperwork. We spoke about primary headache, and we spoke about those with no red flags and what types of imaging recommendations are found in the ACE guidelines. However, secondary headaches, when we are looking for that sinister underlying cause, we are looking for red flags. So red flags come in many shapes, sizes, flavors, and they will be changing constantly as we refine many of these conditions, and we will get into rarer and rarer conditions when CT may be normal, and even conventional MRI may be normal in some cases. So I would be showing some incidents of number 3 and number 4. So you remember the case scenario? I think it was case number 2. If you have the worst headache of life crescendoing within 1 minute, the best test we typically do is to rush the patient to ER, and we would like to have a green channel worst headache of life into the CT scan. Do not pass go, do not collect $200, straight to the CT scanner. There is a very high pretest probability when the red flags are present. We will be able to detect the high density from the blood that's in the subarachnoid space. Not only that, we would then proceed to perform a CT angiogram to look for the aneurysm that has ruptured and caused this. So this is a very, very satisfying high pretest probability study that we teach our medical students and our trainees. Because the next test is a CT angiogram, and the study after that will be the interventional radiologist deploying a coil to protect the aneurysm from future rupture. Scenario number 4 is also in the poll quiz that we underwent. So here are 4 separate patients who have different appearances of for their headache. So in patient A, you see, it's pretty weak, this one. In patient A, we have a large abnormal lump on the right side of the picture. That's sharply marginated. In patient B, in the bottom row, there is a poorly marginated tumor in the brain as well. In patient C, the headache is accompanied by either an HIV positive history or a cancer primary positive history. And patient D may have some other red flags, such as positional headache, and these can be diagnosed quite easily, and again, a good pretest probability for meningioma and glioblastoma, as well as the very typical toxoplasmosis in HIV/AIDS, and of course, metastasis in a known patient with primary. Now, to a radiologist, in patient C, the ring-enhancing tumors that you see, the ring-enhancing abnormalities that we see in the brain can be due either to metastasis or toxoplasmosis or abscesses, multiple differential diagnoses. However, combined with a good history provided by you on the request form stating HIV status and known cancers, we will be very, very good combination to make the correct diagnosis. For patient D, it's a very rare tumor that is very hard for us to see, and here you can see my pointer finally working. The abnormality is in the midline. This is a very, very subtle and difficult diagnosis to make if we're not paying attention. So there are outliers, there are exceptions. Some abnormalities are pretty obvious from the back of the room, some abnormalities less so. So the word on sinusitis that I wanted to say, ENT referral is much, much better. So in conclusion, from the radiologist's point of view, we want to image wisely. We want to have appropriateness criteria. Why? Because it allows us better access to those patients who do have an abnormality. If we decrease the number of negative studies, this increases our safety. In my practice, every day, we will have headache, 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 headache. So many of these patients are going to be normal. But out of the haystack, there may be one patient that's lurking in there. We would like to have the luxury of time to analyze each individual picture, but we can't do so safely if we don't have good appropriateness criteria. Thank you very much for your attention.
Thank you, Professor Lim. For our last speaker of the day, let us welcome Clinical Assistant Professor Gilbert Tan to share his presentation on managing patients with headache in primary care, challenges and opportunities. Professor Tan, please.
Hello. I think I'm standing, being the last speaker is always a challenge because you have gotten so much information, so I'm just not sure how much more will get into your head, right? But I think most of us in the audience are general practitioners. I'm also a family physician. So I think you might probably understand some of the challenges that we face as we deal with our patients. But I want to share with you some opportunities as well. So I'm going to just keep this talk simple in a way. I'm just going to talk about 3 challenges and 3 opportunities. So the first challenge that we face as the first port of call when patients present with headache as a symptom is that really there is a range of conditions from self-limiting conditions to very serious conditions as we have seen. So if you look at the picture in the middle, I think sometimes Tristan talked about picking a needle in a haystack. For us, GPs, maybe it is like trying to unravel the wool when it comes to headaches. So I think in order to learn all the various conditions and all the possible conditions that could occur, I think the next challenge is really having an approach will be very useful. And lastly, as frontliners, we see patients from the whole range of the life course, from the pediatric age group to the adult, as well as to the elderly. Indeed, so as our population ages. And we also need to consider special groups like female of reproductive age group. In terms of opportunities, I think we are poised to correct misconceptions because we're the first line. And there's availability of guides for us. And lastly, I'm going to talk a little bit about patient education. So I think various statistics have already been presented, so I won't talk very much. Just to note that the complaint of headache, although it's a commonly seen symptom in primary care, there are many, many causes. And really, thankfully, the data shows that less than 1% of this headache is due to something that is very serious. As primary care physicians, I think we need to also be involved and focus on the biopsychosocial model, that all headache is not equal to something pathological, but it could be affected by the patient's social status, the circumstances, as well as the effect of this condition affecting their psychological well-being. So I think what we're trying to say is that we need to be considering the whole person as we deal with the symptoms. So I'm going to go with a case vignette which you have already gone through. So just now we had that lady who was, I think, about 32 years old, right? So time has passed. She's become older now. And she comes to you now saying that she's got a pulsatile, unilateral, severe headache with photophobia, phonophobia, nausea, vomiting. And she used to have this about once or twice a month, but it is getting more regular. And therefore, she has been taking diclofenac and paracetamol almost daily for the past 3 months. But it has helped her a little bit. However, she has come to you wanting to take stronger medications. So I think this is not something that is unfamiliar to us. So let's see how we're going to unpack this presentation. I think the first task, as what has been shared earlier on, is we go back to basics. We teach our students that a good history is so important, and a physical examination, because that will really enable you to pick out what is serious and what is not serious. So I think being able to do so, and especially when we learn that the primary headaches are they have special features that should be picked out with a good history. So I think that should guide us. And obviously, we need to also identify the rare headache for which it is due to a serious condition. So it's like a plate of fruits, right? You look at it, they all look the same. But which is the one that is sour? Which is the one that is not good? And that's our challenge, to pick out what is serious. So I want to suggest that maybe one way we can look at it is using John Mattach's diagnostic approach to symptoms. So in the approach, we ask ourselves 5 diagnostic questions. So we ask, what is the probability diagnosis? So if you see a bird flying in the sky, what is it most likely going to be? Something that's common, right? And number 2, what serious conditions must not miss? Number 3, what are some pitfalls? These are things that if we don't think about, we might not consider them and we might miss them. And the 7 masquerades, which are conditions that are sometimes overlaid with the presentations that if you don't think about it, you also don't manage it. And lastly, what is the patient trying to tell me? Okay, so applying this diagnostic approach, I think the first one about probability diagnosis. So again, I won't say very much in terms of the causes, but if a patient comes to you with the complaint of headache, chances are it's going to be something that is not serious, self-limiting, and in our current context where we have very high rates of acute respiratory infections, headaches due to infection of the upper respiratory tract is going to be something that is certainly a common cause. And we talked about the primary headaches, especially if you can elicit the features associated with them. And we also want to consider some special situations. We talked about when the headaches become prolonged or when it's due to other matters. So really consider what is the most likely diagnosis in the presentation. Now, the second question that we ask is, what serious disorder must we not miss? So we talk quite a lot about the red flags. For example, symptoms that suggest a bleed, if the patient has a history of cancer, infection. I think all this has been covered. And this Snoop 10 with 10 Ps is something that is useful for us as a guide as we evaluate what are some of the red flags that we need to exclude. Question 3, we ask ourselves, what are some of the pitfalls and things that you might miss? So for example, if a patient has a neck problem, a cervical spondylosis, neck symptoms, that could sometimes cause pain to transfer from the cervical area up to the head, giving you a headache which you might think, is it due to the head or is it due to the neck? There are other causes that we must think so. It's not just what is it in the brain that's causing the headache. So things like eye problems, ENT conditions, sinusitis, as we talked about. So really, if you don't think about this, then you might also miss them, okay? Other things include exertional, due to whatever reasons, as well as if the patient has, let's say, diabetes, hypoglycemic symptoms can also cause headaches. So the pitfalls that we hope that we don't fall into is also to over-investigate. We are here talking about how to not order CT or MRI unnecessarily, right? And we also recognize that there's combination of conditions. So some conditions don't just come on its own, but it could be overlaid with other conditions. For example, if a patient has multiple chronic conditions and presenting with a headache, you need to consider whether the other conditions are affecting it. And lastly, I think sometimes in the busy practice, we can end up dismissing symptoms and to say that, okay, this sounds like migraine, without going through a full detail. And of course, you do not want to be the one that's going to miss the patient with something serious, like for example, a space-occupying lesion in the head. Okay, so this question helps us to frame what are some of the pitfalls that we should not miss. Question 4 looks at the 7 masquerades, which are conditions that, again, can affect the presentation of symptoms. And particular to headache, I think depression and drugs are very common masquerades that come with headache as well. So I think in the history, I think Dr. Yasmin mentioned that in the history, you also want to consider checking the mood of the patient, depressive symptoms and anxiety symptoms. Useful. A drug history is important as well. And lastly, is the patient trying to tell me something? Where I practice, if we have the patient coming many times for headache, you might think that it's a malingerer or ganking, right? But is the patient trying to tell me something? Could it be a cry for help? And therefore, this question helps us to consider whether is there any hidden agenda. It could be an affective condition like depression, anxiety, presenting primarily a headache because not sleeping well, and then you get headache. So I think it is useful for us not to brush the symptoms aside, but also to consider, is the patient trying to tell me something? Okay, so I think history has been covered, so I just want to say that a good history is essential. And in physical examination, I think taking a blood pressure is important, right? Because you touch the patient. And I think a physical touch is appropriately done, is useful to establish that therapeutic relationship with the patient. And of course, investigation is what where the clinical need requires. A little bit on the management. I think the management should be patient-focused because you arrive at a working diagnosis. And not just arriving at a diagnosis, I think a very important part of what we do is to explain the diagnosis and to assure patient. And patient education is important because I think a lot of times we do not explain what is the condition about, and therefore the patient might have fears or uncertainty. Okay? The last point on the explanation about the use of medication, or rather the overuse of medication, cannot be emphasized because patients might just take medication as a very easy way to to help the symptom. This is a algorithm, I think been shared earlier on, so I'll just go through. And just want to summarize, when are conditions which you should refer to specialists? So we talked about primary headaches like migraine and tension type. Again, in the primary care context, if you have given optimal therapy, you have ensured that you have done whatever you can, but it's not improving, then I think it's perhaps time to seek a second opinion and to refer onwards. We have learned that cluster headaches should be referred, especially if it's a first presentation. And secondary headaches, we need to determine whether it's urgent or whether there's significant red flags for which we need to refer onward as well. And of course, if you're unsure, diagnostic uncertainty, you will refer. But we hope that as we create more awareness, as you're confident to diagnose primary headaches in terms of knowing the features in primary care, you have diagnostic certainty, and therefore you don't end up having to refer. And of course, when you have started treatment and there's lack of response and there's frequent attendance, you might want to consider, is there something else? Am I missing something? Therefore, you'll be more appropriately referred. So I think communication and managing the expectations of the patient is of utmost importance as you manage the patients. Just a little word on special population. So some of us in our practice might see the pediatric age group. And in this age group, most commonly they would come with infection, such as ARI, causing or fever. And therefore, that might be the commonest cause of presenting with headaches. But do note that in the pediatric age group, there are also patients that might have migraine. So knowing some of the features of migraine in the history taking will be useful. And in the day and age where we are looking at devices all the time, eye strain because of overuse will be something that we need to look at. And of course, at the back of your mind is space-occupying lesion. But usually this will be associated with other symptoms, neurological findings that you will see as well. Peculiar to the pediatric age group, we treat both the parent and the patient. Okay? For the elderly, we just also need to know that whatever is recent onset, especially if it's sudden, escalating, you need to be cautious about this. And pregnancy has been covered earlier on, so I will just skip this as well. Again, this slide just to emphasize that analgesia-induced headache or rebound headache is common. You will find it when you ask about this, especially on their drug use or medication, painkiller usage. Okay, so you need to manage this as well. So we come to opportunities. I think in primary care, we are able to correct misconceptions. So a patient might come to you and say that, oh, my headache is due to migraine. I have migraine. But I think you need to know what are some of the features. We know that tension headache type, although a bit harder to be very specific, is more common than migraine. But migraine has its own specific features that if you are able to confidently diagnose, then you will be able to manage. The second thing is about, doctor, I need stronger painkillers. Again, it is not just about medication. I mentioned about the overuse. But I think, especially in certain primary headaches like migraine, managing the risks, the triggers, will be something that is important for us. And the third thing about chronic headaches need a brain scan. So I think Choyson earlier shared that if we refer every single headache unnecessarily, then all this resource to conduct the neuroimaging and even to report them will be overtaken, and that will affect the whole system. So the very last line, if you can read, is assurance of a scan versus the time to clinically assess and talk to the patient. I think in the busy practice, sometimes it's so easy to just trigger a referral versus trying to explain the condition, get the patient's buy-in, set a time for review. But I think it is worthwhile doing so. Okay, so there's available guides. So I think today's objective is really to create awareness. So there's guides available for us. For example, the ACG that we are looking at. And patient education is also important. So it is first important for us to establish a therapeutic relationship, especially when patients have chronic headaches. Right? They jump from doctor to doctor. And therefore, if you can engage the patient to come back to you regularly on a regular basis, actually some of these headache problems can be resolved with time. right? So we also use time as a diagnostic tool, and patient education as what has been shared earlier by the previous speakers. Other tools could also include things like a headache diary, or in some situations, you might want to consider referral onward to our allied health professionals, psychological services for things like maybe cognitive behavioral therapy. Okay, so I'm going to end off with some practice pearls. A good history and physical examination is essential. Okay, so that one cannot escape. I think we need to do that. And definitely be aware of red flags. And in the elderly patient with a new onset headache, please be careful and consider organic cause unless proven otherwise. In patients presenting twice within 24 hours with headache, nausea, and vomiting, consider very serious causes. This is not just a migraine. And beware of the sudden headache. We talked about the thunderclap headache and the features. Consider headache due to other places, elsewhere in the head and the neck. And in recurrent migraine, we need to manage the triggers and prophylaxis. Be careful about the use of narcotics because it's potentially addictive. You don't want to create dependence. We use time as a diagnostic tool, and I will add on to establish a good communication with the patient. Always document and always have a plan for review. And finally, we should know when to order CT, MRI. We might not have direct access to it, but we might need to know when to refer to our specialist colleagues. So with that, I end. Thank you.
Thank you, Professor Tan. We would now like to invite the moderator, Professor Tan Che Heng, and speakers, Dr. Bernard Chan, Dr. Yasmin Idu Jion, Clinical Assistant Professor Gilbert Tan, and Professor Choi Sen Lim to take a seat on stage for the panel discussion. The panel will be addressing as many questions submitted from the audience as they can during the discussion. Let's invite Professor Tan to start the session. Professor Tan, please.
Yeah, thanks. I know it's getting late, and but we do want to make sure that your afternoon session has been worth your while. And there have been a few questions posed, so I'd like to quickly get on with it. So the first question I'd like to ask has 3 votes, and this question is there such a thing as cervicogenic headache? How about tension headache? And I know that actually more than one person has a question like this, so I think Gilbert has already specified about cervicogenic headache, and perhaps the question here would be a little bit more detail about cervicogenic headache, and how do we recognize it in practice? Maybe we can hear from our neurologist colleague first.
According to my understanding, I think cervicogenic headache is a little bit different from tension headache. If you go back to the IHD diagnosis, it's actually higher C1, C2. So whereas the usual tension headache is actually lower down cervical spondylosis with neck pain and scarf stiffness. So I think if it's really cervicogenic headache, maybe I would refer to the headache specialist, Yasmin, and maybe you need some imaging and so on.
Yeah, so actually cervicogenic headache in the truest sense, right, it's actually not so common. The common neck aches and sprains, they are not, I mean, if you refer strictly to the guidelines and the criteria, they don't form into this category called cervicogenic headache. And a lot of times, tension headaches and migraines, they do have a lot of referred pain to the neck. They share the same underlying, pain center, which is your trigeminal cervical complex, which is located at the back. So you can get migraines that go to the back of the neck. At the same time, you have neck pain that radiates to the front. So it's actually very difficult. True cervicogenic headache usually arises in the setting of someone with perhaps rheumatoid arthritis with atlanto-occipital joint subluxation, or those with very clear osteophytes on imaging. So those are cervicogenic headaches in the truest sense, or headaches that come on in the setting of a whiplash injury. So those are true cervicogenic headaches. Most of the time, people who are labeled with cervicogenic headaches don't truly have cervicogenic headaches, but they just have a lot of neck sprains.
Thank you. And I wonder if this answers the questions from the audience, and whoever asked the question, is it clear enough, or do you want to elaborate on your question? Okay, I think we can move on. I think there was a question here about the mechanism causing headaches from diabetes. Maybe any of you want to take that question, maybe from Gilbert first, and then hearing from our neurologist. Thank you.
I think in the management of diabetes, especially for patients who are, let's say, on insulin therapy, right? So when perhaps they might be injecting themselves, not eating enough, and they get hypoglycemic symptoms. Sometimes it could present as, some of my patients get headache, but it usually comes with other things, feeling hungry, a bit of perspiration. So I think in that context, I would say that is a cause, and therefore, as I presented earlier on, it's one of the masquerade. So really, you also need to kind of determine, especially if the patient has diabetes, whether he's taking the medications correctly, especially in relation to meal times and especially those on insulin.
Any comments from Yasmin or Bernard? Yeah.
I'm just thinking, in the other extreme, I think hyperglycemia is not really associated with headache. Sometimes it's associated with tremor, seizures, or some rare movement disorder. But of course, if you have hyperglycemia, then you might, in your back of your mind, with some sinus pain and so on, you worry about fungal infection, just in the back of your mind. Don't miss any serious infection.
Okay, thanks very much. The next question, I think, goes to Choi Sen. So the question is, when the CT is normal, what is the red flag to order MRI? I guess this is fairly non-specific, but you can perhaps answer the way you interpret it.
Actually, this is actually probably better as an MDT, because I think for the people the patients who have a normal CT, when they go back to the doctor, what happens in that consultation is going to be the one that triggers an MRI. In other words, if you have a normal CT, my report is just going to report normal CT. It doesn't say, there are some conditions where the CT can be normal and maybe you should consider doing an MRI. I'm not going to do that, even though, it sounds like good business sense to drum up business for my own imaging clinic. I don't work on that kind of commission basis. So it doesn't help me. And it will defeat the purpose of appropriateness criteria. So actually, the key importance is when the patient turns up and says, my headache is still here, what am I going to do about it? That's when the conversation to trigger, should we move on to an MRI just in case we have missed something? Whilst I, wait for my clinical colleagues to think about that, I do teach my trainees, the advanced trainees, that there are two conditions that a radiologist must be aware of and look very hard when we see a normal CT. In a situation where it is a true negative, omitting all the cases where there was a positive finding but we missed it, those do happen. When it is a completely normal CT scan, there are two conditions in headaches that we must be aware of. One of which is venous thrombosis, because not all venous thrombosis comes to you with I am a woman on oral contraceptives and I've been having headaches. Please rule out venous thrombosis. We did a review of all of our cases of like 50 superior sagittal sinus thrombosis proven positive cases. Only in one case was the history given headache. Please rule out venous thrombosis. The other cases, 99% of them, were just headache, not specified. So venous thrombosis is one of these rare conditions where CT can be a true negative. The other is intracranial hypotension, which is a postural headache caused by a very complex set of mechanisms, and it's a very, very difficult condition to diagnose without MRI. So those are the kind of two things that we think about. So can we get some of the clinicians to weigh in on this decision-making process? Thank you.
Yeah, especially I think in the course of writing up the guideline, we deliberated a lot on the red flags, how much to put in, how much to take out, etc. So perhaps Bernard, you can comment quite quickly first on this point.
I think our guidelines is more like clinical based, whereas the reference guideline is actually the American College of Radiology is more radiology based. They actually go into a little bit more detail. So it's actually some of the conditions actually, if they are not urgent, if you want to look out for these conditions, like low pressure headache, we should actually order MRI. So if you do a CT scan just for urgency, maybe those you really still suspect, you might actually order an MRI. But there are other conditions like, for example, head injury, which is CT first. If patients have deficit not explained by the CT, then you can go for an MRI, which is actually explained further in the ACR guidelines. Sinusitis, not usually neuroimaging, but if you do a CT and if there's sinusitis and there's intracranial extension, you want to do MRI. So these are the two that they actually mentioned. But most others, if it's urgent, like SAH, you do a CT first. Depending on the condition, sometimes even stroke or venous sinus thrombosis, you might actually want to do an MRI to further depict the stroke or the DWI distribution or the stroke pattern and so on. So I think it's a more clinician-based and examination-based and what is the patient's progress and response to treatment. Yeah.
Yeah, thanks, Bernard. And actually, the next question relates to quite a bit of what Yasmin you shared during your talk. So this question is about a patient with migraine since 30 years old and now 55. You talked about the bimodal, although I know the first peak was younger, as you mentioned. So what do we order if the headaches now seem worse?
So I think for this question in particular, if the headaches are now seem to be worse, aside from the frequency, the severity, look for new red flags. Sometimes in older patients, they have a new development of an aura. So that I would think is a good indication of neuroimaging, presence of an aura. Obviously, if the patient has got other red flags that are not mentioned here, so things like weight loss or neurological deficits, or any forms of seizures or poor vision, that would be an indication for imaging. So I think if you follow the ACG guidelines, most of this would have been covered under the recommendations. Always, I would say, empirically treat first, because a lot of times with empirical treatment, most of these conditions actually get better. Even though this is migraine that has evolved over time to become chronic. So most of them with good prophylaxis, with good multimodal treatment and treating the patient as a whole, most of them actually do get better and they revert back to episodic forms.
I'm also curious, Gilbert, how do you manage? Because as we crafted the guidelines, we did think about the fact that obviously the GP is not the last line of diagnosis, treatment. There's always the opportunity to refer to a neurologist, a specialist. So like, for example, in this particular case, right, what would you typically do?
So I think we go back to basics, right? The history, is the patient trying to tell me something? Is there underlying issues? Or is there actually a new problem? So we, just because you have a history of migraine, it does not mean that your new headache might be due to migraine. It really is very contextual, and it would depend on, definitely you need to properly asking about the background history of that migraine and how has it changed. And really depending on how the patient is affected by it functionally and the level of anxiety and what has been done, then you have to make a clinical judgment, whether are you going to adjust the treatment, give a trial of therapy, again using time as a diagnostic tool, maintain that communication with the patient, and a plan for review, and then you decide what is the next step. So we should not just reflex, nah, it's okay, it's nothing, or neither should we reflex. I think better refer to specialists, so we don't really want that as well. Yeah.
Okay, thank you very much. I'm just going to pause here for a few seconds to see if anyone hasn't typed in but want to just shout out a question to our panel. Okay, I'll move on. There is a question about hormonal cause for headaches, and the question is, can LDOCPs help? So Yasmin, I don't know if you want to take this question.
Does anyone else want to take this question? LD OCP, I mean, you're talking about low dose OCP, is that what LD stands for? Low dose OCP. Can they help? Potentially, yes. So it depends what the cause of the headaches are. So for people with menstrual migraines, a lot of times it's because of fluctuations, particularly the drop in estrogen level just before the menses actually start. So OCPs, especially when they're taken on a regular basis, without the pill-free week, can stabilize the hormonal milieu in the body. So that can help with hormonal headaches. But if you have combined OC pills, meaning estrogen and progesterone, sometimes the progesterone component can exacerbate headaches. So it's a two-way thing. I mean, while the estrogen helps, the progesterone worsens. So it's not so clear-cut in that sense.
Of course, the lady probably answered it very well. Bernard, as a neurologist, any comments on that? Or you are okay, you think that's, yeah?
Actually, I would declare that my primary interest is actually general and actually a stroke neurologist. So my worry is that for stroke, if a patient has migraine or migraine with aura, there's actually a slight increase in stroke. And as we learned from medical school, migraine with aura, and then with OCP, with hypertension, with smoking, these are all cumulative together. So they actually increase stroke risk. So I would put OCP for patients who actually have very resistant migraine, resistant to other treatment before I consider OCP. Don't know whether you agree.
Okay, yeah, thanks. That's helpful, and I hope that answers the audience's question. Actually, yeah.
Hormonal basis in a man rather than in a woman? I actually am not aware because I know estrogen is associated with better control of migraine, but I'm not aware that testosterone or anything actually increase migraine risk. I don't know whether you...
Yeah, I think when we talk about hormones, we're talking in primarily women, because migraine is technically much more prevalent in women. In men, I mean, if you're talking about hormones, it's not just the sex hormones. You have to think about thyroid hormones. I mean, they also play a part, especially in uncontrolled thyroid disorders, etc. But in particular, testosterone, I mean, it's not so clear-cut. Although there are, I think, reports of testosterone shots, giving rise to headaches. It's a common side effect. But aside from that, I'm not aware of any other correlation with migraines.
Thank you. I want to direct the next question to Gilbert. Gilbert, you briefly mentioned, of course, I think in our practice of medicine, the first thing we don't think of is that the patient is a king one, right? But I think there's an interesting question here about perhaps NS men, due to wearing army helmets, having headache. Is it common in your practice, and what do you typically do?
I think it depends on where you work, right? If you work in the Army Medical Center, it might be more common. What's the typical solution? Excuse helmet, law. Well, I think it could be multifactorial, right? It could be an ill-fitting helmet. You could be training in the sun and you get a bit of heat exhaustion, not enough hydration. So again, I think I will go back to the history, find out a little bit more. Is the patient trying to tell me something, right? So common or not, I really think it's your context of practice, and typical solution might be really just the simple general advice of hydration, the fit of the helmet, etc. Yeah.
Actually, we also have a lot of, in the neurology clinic, we also have a lot of referrals from NS boys. It's very common. I think at least 20-25% or even 1/3 that they want us to write a memo to excuse from helmet. I feel that NS itself is probably also a stress factor. So if it's really related, maybe because of temperature, maybe because of the tightness and so on, I just write to excuse, because I think controlling the condition is actually of primary importance. So yeah, I'll just write a memo.
Thank you. I'm mindful of time. We do have one more question, but I thought it was important I asked this question at this point, and it's somewhat related. I think when we were crafting the guidelines, we were also very mindful that we wanted to make sure that our physicians felt empowered with the knowledge and in the guideline to know when to refer and when not to refer. And one of the scenarios that we had discussed was, what if the patient requests for the scan? how do you manage that, right? So it would be great to hear from primary care as well as from the specialist care. So maybe let's start with Gilbert from primary care. How do you manage that?
Where it starts, right? So again, it's the assurance scan versus you taking the time to find out what is the matter. Therefore, again, it goes back to the history. And I think beyond the history is your therapeutic relationship with the patient. I just share maybe a story, not a story, I mean it's a previous experience that perhaps might lend some thinking through this. So I just passed my MAT many years ago, family medicine. So armed with more knowledge, when I saw a patient who had a headache and immediately they said, I come to see you today because I want a referral, right? So in a busy polyclinic setting where I'm practicing, it's so easy to just reach out for the referral letter and just write it, right? And that's it. But actually in that instance, I took the pain to find out a little bit more about headache, and I explained why there's no red flags at this stage, why you do not need a referral. Maybe can we try some therapy and come back and see me again? And the patient took it, right? So that's one approach. Yeah.
Thanks. In the case of a specialist clinic, I would imagine that literally everyone comes and then gets an order for MRI. How do you manage the request?
It's actually similar to what Gilbert has mentioned. You have to understand why they are requesting it. I mean, sometimes the reasons are quite, it's good to have underlying reasons why. But at the end of the day, you just give them, give them your input, what you suspect the diagnosis is, what is the pre-test likelihood of getting an abnormal scan, as well as the risk of those abnormal scans. Offer them treatment as per usual, and then offer them the benefit of taking treatment and seeing whether or not that works out. So long as they feel that, if they trust you and they feel like there's an avenue for them to return. Most of these patients, actually, they change their mind and they retract. They don't want to go through the scans. At least that's after you talk to them. You have to talk to them. It's whether you got time to talk to them.
Thank you. Actually, that's true, right? So the amount of actually time and your rapport with the patient, I think, makes a huge difference. Bernard, any comments on that, or you want to take the last question? That's fine too.
I think I just want to tell you a story. When I started to practice neurology in 1994, it was in a district general hospital clinic in East London, end of Central Line. So my consultant will tell me, okay, for the headache patients, for everyone, order a set of skull X-ray. And when the skull X-ray come back, you look at the skull X-ray in this way, this way, this way, very professionally, and tell the patient very confidently, you are normal. Of course, this is completely placebo effect, and studies have shown that if you do a CT scan in emergency, then the return rate will be cut by half if you do a scan. So this is reassurance. But if you think of it, this is not good medical practice. This is completely no evidence base. It doesn't help the patient. It just trick them or whatever. So I agree with my colleagues. You do a very careful examination. In specialist clinic, you just hit all the spots, migraine, the diagnosis, and then you do a very professional examination, do fundoscopy. The examination is a little bit different, so the patient will be reassured. So they are on board, then you tell them you don't need it, you just treat first. I give you 3 months of medicine because my clinic is very busy, but you at least try 1 month of the prevention treatment. And then it is a stepwise. If 1 month doesn't work, then the second month you increase the dose, okay? But if the headache is very bad, you can have the option to call the clinic to return early. So, most of the patients I can actually escape without ordering a scan. And primary care, you might not have time to do so much examination, but you have another advantage. You have a report, you're already seeing the patient, they are already your old patient, so they'll listen to you. So, we try our best.
Thank you very much. And the last question, I think we will ask our headache specialist, Yasmin. Can tight trapezius muscles trigger headache?
Oh, of course, definitely. So tight neck, tight muscles, they can trigger headaches, particularly if they're, in the neck-shoulder regions. Sometimes when the neck muscles are too tight, they can get trigger points, which are particularly tender spots in the muscles. Unfortunately, no easy solution except, just general stretching exercises, physiotherapy, massages, acupuncture, I mean, this kind of stuff. Yeah.
Thank you. And I hope none of you have a headache after this session. I think we've all enjoyed the sharing by our panelists. And I think if there are any questions, particularly with, go ahead.
You mentioned 4 millicircles for a scan of head. What is the normal chest X-ray and how many millicircles?
So radiation dose related to...
I find that if you compare scan radiation dose to chest X-ray, the patient understands.
Excuse me while I look it up on the internet. Let me take this offline with you afterwards. But your strategy is a sound one because the CT scan is more than a chest X-ray. However, the manufacturers and engineers involved in the scanners are always working hard to try and bring that down to the effect that we now have very low dose CT scans for lung cancer screening, very low dose CT scans for angiography, and we are decreasing the dose all the time. Therefore, the converse now becomes a problem. Everyone thinks it's safe to do lots and lots of CT scans. And this is particularly true in children. So there are also people who are physicists, who are modeling mathematical answers to how many new cancers are going to be discovered in the 20 years after these patients undergo all these additional radiation-based tests. So these are moving targets, and I'll get back to you on the exact numbers. Thank you.
Thank you to the audience as well for all the questions. So in the interest of time, I think we have to call this session to a close, but I would like to just highlight that the ACE document is not a static one that's going to stay for the next 2 decades. It will be subject to review and renewal. So if you have any questions or feedback, particularly in the way the guidance is crafted, the team is more than happy to receive your feedback. At the same time, we also hope that you will be able to use the guidelines effectively in your practice. So please give a round of applause to our panel today. Thank you. And thanks everyone for your kind attendance. Thank you.
If you're interested to read the ACE clinical guidance on when to order CT or MRI for headache, you can scan this QR code to access it. Ladies and gentlemen, I hope you've enjoyed today's seminar. Thank you for taking time out to join us today.